Hello, this is a 20-minute residence teaching lecture. The title is All You Need to Know Not to Miss Occult or Atypical Fractures. It's a very daily and practical talk. I have nothing to disclose. This is the structure of this 20-minute lecture. We will cover some basic information. We will talk about special things at the upper extremity, the thorax and spine, as well as the pelvis and lower extremity. Before we start, it's very important for this specific topic that you know your anatomy especially and normal variants. I always advise to use online atlases these days because they are ready and always available online, and most of our people are really always online and connected to the internet these days. It's also very important to know the anatomy of the normal variants, and there is a key book out there from Theodore Keats. It's a very traditional book, but it's the best ever written about this topic, and it's always mandatory to have this on, in the bookshelf behind the reading place. There is of course also some literature available, some of which is quite old. You can see here, this is a publication from 1967. It's called Commonly Missed Orthopedic Injuries. And you will see, we will come back to these publications later on again. You will see that there is nothing older, nothing old in this publication. Is also a very remarkable up-to-date publication despite it's basically 60 years old. There is also some modern publications such as here in Seminars in Musculoskeletal Radiology published a few years ago. I myself was editor of that special edition. You can see we covered a lot of topics regarding these things. And there is also of course online tutorials already available, such as from Chris Beaulieu, a very distinct and very good radiologist, which I know personally, and I can also recommend his lecture here about subtle fractures, which are not to miss. And more than ever, knowing is seeing. Especially if you're dealing with occult fractures, you know where you have to look for the fractures, otherwise you will miss them. So let's start with the upper extremity. In the year 1967, Dr. Epley published this aforementioned paper, and here you can see AP radiograph of right shoulder, and there is something abnormal. It's a very classic case which can appear every day still in our clinical routine. And the solution is, as always, given by the second plane. As you can see here, the lateral view shows clearly a dislocation of this shoulder. And it was a posterior dislocation in this case, which is not very frequent, but it can occur every day in some percentage of all shoulder dislocations. So despite these publications are quite old, there is no problem with regard to the actuality of those cases. This is a typical case of an anterior-inferior shoulder dislocation, which is the most common dislocation. You can see the classic sign if you see the patient real in front of you, and on the left-hand side you can see also the radiograph of that particular patient. You can see there was a huge dislocation of that shoulder. There are some fractures associated with dislocation. First of all, there is this famous Hill-Sachs lesion, but you can also have a fracture of the greater tubercle and of the glenoid, of course. Sometimes these glenoid fractures are not so obvious, as in this case down here. Then you need CT to evaluate the dislocated fracture fragment. I also recommend to perform a CT in all patients who are undergoing surgical repair of that glenoid fracture, because typically the clinicians use these information from cross-sectional imaging, because they can much better evaluate the defect, the bony defect of after dislocation. So this is a patient who has a fracture, but where is the fracture? It's quite subtle, but it can be appreciated if you look quite closely. I give you a minute time to look for the fracture sign, and maybe some of you already have detected the fracture. Yes, this was a fracture of the coracoid process. You can see that much better, of course, on a CT examination, but if you may look closely, you can also identify these kind of fractures on standard radiographs. However, it's very difficult to see, I agree. If you are not able to see it, maybe here, I try to use these functionality here with these markers, but maybe here you can see that there is a fracture, but it's not so easy to see. Another example from that publication from the year 1967. This is a AP and lateral view of medial epicondyle of a child, and despite the image quality is not the best, I see everybody can see that there is something abnormal ongoing here. And also the text of that older publication is quite good. So let's read. When the epicondyle is merely avulsed from the humerus, there is also no diagnostic problem, especially if the normal elbow is x-rayed for comparison. That has been done in the earlier days of radiology quite often, that especially in the childs you image also the contralateral healthy side. However, difficulties arises when the epicondyle is not merely avulsed but is trapped inside the elbow joint. A child presents with a swollen elbow whose movements are considerably restricted in an X-ray in which no fracture is obvious. But on careful inspection, the film shows that the elbow joint harbors a loose body, in reality the trapped elbow. I think that is quite a striking image here, and I think once you have seen it, you will never miss it again in the future. One of the best websites I know is at the moment Radiology Assistant, and my staff is using it extensively throughout the day. You can see that there are a lot of fractures in children described, and they are really very helpful for the daily clinical routine. All sorts of elbow fractures can be read here, and there are also good examples for each of them. I really advise you to read about the fractures in children, because they are not so easy to see if you never have seen examples for these different fractures. You really need to know about the mechanism and the location of these fractures, and then you can see it. What you should always remember are the basics, the lines. There are two important lines which help in the diagnosis of dislocation fracture. These are the radiocapitellar line and the anterior humeral line. So for me, always the easiest one is the radiocapitellar line, which is a capitellar line, which you can see here. So it's a straight line through the head of the radius, and it should always basically run through the center of the radial neck, and the ascent of the capitellum. The anterior humeral line is drawn in the anterior part of the humerus, and as you can see here, this is a very important line because it shows you very nicely supracondylar fractures. In cases of supracondylar fractures, the anterior humeral line usually passes through the anterior third of the capitellum or in front of the capitellum due to posterior bending of the distal fragment. So this is very important that you always remember these two lines, because they give you a really a hint for the most frequent fractures in children. Please be advised that radial head fractures are not that easy to see, especially if you don't have these special views. We perform those special views in all our elbow examinations, which means we always acquire 3 planes. So the AP, the lateral, and this dedicated plane, which is also called coil examination. And it's a quite good projection to see radial head fractures. Remember that there is also this fat pad sign anteriorly and posteriorly here, where you can see the joint diffusion, which is created by any fracture in the elbow joint. This is another case where is the fracture? That's the question in this case. You can always outline the radial head, but this is not again a radial head fracture. We already had that, so you need to look for another fracture sign. And some of you may already know that there is also another fracture which is usually a little bit hidden, and which can be found if you look very closely on the ulnar bone. Here, this is a better outline of this case. You can see there is a fracture of the coronoid process, and it's a fracture which is typically associated with some kind of instability of the joint. And it's a very important fracture, because if you miss it, the patient will have long-term problems. So very closely look on the coronoid process in the elbow cases, especially if you don't find any fracture elsewhere. Let's move on to the wrist. The scaphoid fractures are of course well known that they are frequently missed. Why is that so difficult? Well, the scaphoid bone is a very complex bone, not only because of the arterial supply, which is very important in terms of fractures, but it's also a very complex bone in terms of its anatomy. So it has a very distinct 3D shaped anatomy, and I once heard a 30-minute lecture just about the scaphoid bone, so you can really talk a lot about the scaphoid bone if you wish. The basic things to remember is that depending where the fracture is located, in the proximal or distal part, there's a different problem with the arterial supply. So some fractures tend to have a much higher tendency to osteonecrosis, as in these cases where you have a little fragment here, which is also not very well supplied by vessels. So the smaller the bone, the more likely it is that there is osteonecrosis. Scaphoid fractures always are difficult if they are not directly seen on the first radiograph to follow up. There are different strategies. Some people recommend repeating the radiograph. These days I would recommend rather CT or MRI or both in unclear cases. We recently had a case where we did all 3 things, radiograph, MRI and CT, before we could find the fracture line. There is another fracture which I think it's very difficult to see on standard radiographs, and this is fracture of the humulus ossi hamati. It typically occurs on falls, or as in this case where during sports, Typically, the patient has tenderness and pain on the ulnar aspect of the wrist, and it's best seen on CT. All the tunnel views are obsolete these days, especially if you have CT available. Then you directly go for CT, and then you can nicely see the fracture. It's not so uncommon that these fractures are also diagnosed as a site finding in MRI for people who do not recover after trauma. So I have seen a lot of first-line diagnosis on MRI in these cases because nobody thinks about the fracture of the humerus. The Triquitom fractures are quite common. You can see here this is a lateral radiograph with all the bones highlighted in different colors, and there is a small fragment in the posterior aspect, in the dorsal aspect of the hand. You can see also there is a huge soft tissue swelling exactly here, and this is a very pathognomonic location for a triquitom fracture. You can see also here on CT the fracture fragment nicely outlined, but if you have this classic sign on the lateral radiograph, there is not necessarily a need for CT just for this. Of course, these days a lot of CTs are performed just to rule out other fractures rather than only this fracture here of the triquitum. So anyway, this is a very pathognomonic sign in radiographic examination of the wrist. Most residents learn about the Gilula rows, first, second, third. They should be always smooth, there should not be a step, they should be in line, as well as the lateral angles. That's familiar with most of the residents. They learn it also in all the textbooks. And here is an example where you can see there is a huge gap between the SL distance and here you can see also that the lines are not well here in as smooth as they should be. So this is always a very good indication that there is some dislocation ongoing or some pathology on the ligamentous level, which is not directly seen, of course, on X-rays. Let's move on to thorax and spine. Here I have a case which I made a big mistake a while ago, and where I had a huge wow effect. So a patient came in after doing this kind of sports here, where he hit a obstacle, and then he compressed one of his ribs, and he was coming in and he was showing me with his index finger where the pain was. It was exactly on the 7th rib, and we did an CT to rule out also any internal injury to the spleen and to the liver and so on. But on the rib, the 7th rib, we could not see anything. We also did a ultrasound in addition, just to be sure in this patient, and I also did ultrasound of the rib. I could not see anything. However, this sportsman is a professional race car driver. This is his race car. So you can see it's a Formula 1 race car, and they have a pretty high load to when they do these sports, especially if they go around the corners. They have a lot of G-force to their body. So I knew that the patient must be super secure in this diagnosis, and if I don't see a fracture, he will race again on the next weekend. I had a big wow because I also did a MRI to be sure that there is nothing. You can see these are the ribs, the cartilage part, and I could not see anything in that patient. I also put a marker here, but there was nothing to see on the ribs. So I diagnosed the patient just with a contusion, but no fracture. And the problem was 10-12 days later he came back, and he had a Femoral 1 raise in between, and then I saw on an MRI this rib fracture. So, and I was really disappointed about myself and my diagnosis early on because I could not see anything. I reviewed the exam. I was pretty sure that there was nothing on the CT, on the initial CT. Going back to the initial MRI, which I did, I saw a little bit of this hyper signal intensity here, but I was 100% sure that these are the vessels. This is the rib here. You can see there is no signal intensity change in the rib at that day, and 12 days later we had the fracture here. So my conclusion was that rib fractures are very difficult to see, even if you know that they are there. I will be super careful in the future with rib fractures. Again, I did ultrasound, X-ray, CT and MRI. In this case, I was not able to see the rib fracture, and 12 days later there was a fracture. What could be the problem? Well, in MRI you need a certain amount of bone marrow space to see the bone marrow edema. In the rib, usually you only have a little bit of bone marrow, and there's a lot of cortex as well. So this could be the issue why I could not see any traumatic bone marrow edema here. The same is usually for the cervical spine, where you don't see a lot of bone marrow edema because the bone is so dense, and it's known that you can miss fractures on MRI and the cervical spine. In the past, I always recommended additional CT in spine injury, and well, after my Formula 1 race driver, I don't know what I should recommend in rib fractures if you don't see them. But anyway, I wanted to bring you this case to show you that this is not so easy sometimes to detect. Coming back to this spine case, you can see that there is maybe a little bit of fluid here in this region around this facet joint, and we did a CT. This is enlightened, and we did a CT, and actually there was a fracture, but again I could not see the fracture directly. It was more like very subtle here, maybe a little bit more fluid, so be careful with these fractures in the cervical spine. They are very difficult to see, and basically CT and MRI are complementary in these patients. For the spine, there are new guidelines out there. They were updated in 2018. And those guidelines, they put a lot of pressure on the clinicians. For example, in variant 1, if the age is greater than or equal to 16 years and less than 65 years, if you have suspected actual acute blunt cervical spine trauma, imaging is not indicated if Nexus and CCR criteria are negative. This means that the clinicians, they really need to be familiar with this criteria, and they need to really do a very good clinical exam, because if they are negative, no imaging is performed usually. However, if these criteria are positive, then these days you go for CT. You don't do radiograph if CT is available, and that's an important message also to our clinical colleagues, especially family doctors, which still recommend or request radiographs in cervical spine injuries, but this is not recommended anymore. Magnetic resonance imaging has a role, as I propose, in the thoracolumbar spine, especially in acute trauma. There are several studies, including some of which I worked together with colleagues, and we could really show that there is an increased information in cervical spine injuries, especially regarding soft tissue injury of the stabilizing elements of the spine. Plus, you see more fractures, some of which are really important for the clinical decision making. as for example in this case, where after CT we only saw a 1.2 fracture, but afterwards this fracture was turned into a B 1.2 fracture, which certainly needs stabilization surgery. So it's very important from my perspective that you perform additional MRI in acute trauma spines, and the current conclusion from the literature is that CT is of course the mainstay in acute spinal trauma imaging. However, emergency MRI provides complementary information and is indicated in all patients with neurologic deficits. It should also be used in patients without neurologic deficits. Let's move on to the pelvis and lower extremity. This is a patient of 72 years old, and she had a fall 1 week ago. The initial x-rays shown basically nothing, some degenerative changes of the hip. Also you can see there is an old fracture here, which was already known. But the big question was, is there any problem back here in the sacroiliac joint and in the sacrum? 1 week later, a CT was performed and there was nothing shown. However, on MRI, you could clearly see there is a fracture line here consistent with a sacral fracture. So why could you not see anything on X-ray and CT? Well, this patient has definitely a osteoporosis, as you can see on the CT exam. And in osteoporosis, you have the problem that you have a X-ray beam going through the bones, and you need to have a certain bone density that this X-ray beam is actually can hit something. So otherwise it goes straight through the bone and you cannot detect anything. So if you want to see anything in these highly osteoporotic patients, you should go for MRI, because in MRI you can see the bone marrow edema and accordingly the fracture. And it makes no difference if you perform an X-ray or a CT, because basically both are the same technique. So you need to change the technique. The ACR guidelines also indicate this: suspected stress or insufficiency fracture of the pelvis and hip, negative radiogram, next imaging study should be MRI. So this is very important to remember, and that you directly aim for an MRI in these patients. Once more, I'm coming back to the publication from 1967. Here you can see an anterior, posterior and lateral view of a slipped left femoral epiphysis. Well, how can you detect it? Well, first of all, you draw a line and then you can see that on a normal epiphysis has a sign like this, whereas here on this side you have an epiphysis which looks like this. On the other planes you can see that there is like a step where in this case it's basically a continuous line. So this is quite subtle, but that's what you see, and we do these kind of examinations still today. So again, this is something which is quite old, has been described for centuries, but has not lost its actuality these days. Again, hip pain in children is a quite difficult topic. Still it is after all those years, and you need to have a very good clinician who also can indicate the correct examination for imaging. Usually there is no imaging performed in early on symptoms, less than 5 days, unless the children are sick or had a trauma. Then ultrasound is a good method, as well as X-ray, as I have shown you here with this old image. And MRI is usually not that first line examination. It's basically if you cannot solve the problem otherwise. Slipped capital femoral epiphysis, like in this patient shown in this old radiograph, are basically Salter-Harris one-time fractures. Here you can see this is again this website, Radiology Assistant, and this is another case here. taken from this website, and again you can here read on this website everything about this pathology. And I can really advise you to use this website to learn more about these child fractures. Please be aware that the examinations must be taken correctly, and if your technicians don't have the experience, you yourself as a radiologist need to supervise them. Otherwise, this kind of examination is not readily you are not readily able to evaluate those examinations. Around the hip, there are many types of avulsion injuries which can occur of the iliac crest, the anterior superior or anterior inferior iliac spine, spinal process, the greater trochanter, the lesser trochanter, the tuberositas, or even this symphysis can be avulsed. Those are quite subtle sometimes, especially in adolescents. It's not that easy to see, and I always recommend to look on the contralateral side how it looks on the other side. Also here, please be aware that those are quite subtle changes. This is a 22-year-old female athlete. Patient came into our hospital. She had no trauma. On the onset, the radiograph taken at the onset of symptoms, we could not see anything. 2 months later, the patient came back and had this stress fracture here on the left femoral neck, readily seen. Stress fractures are quite difficult. This is a patient who had a typical stress fracture of the tibia bone. This is another patient who had a complete fracture based on a stress fracture. Then you already have seen this type of fractures from this first case, and they are quite, but they are quite often, especially in these long distance runners or triathletes. This is a case from a Swiss triathlete here. Then stress fractures can also occur on the calcaneus, as you can see here on this subtle line. Of course, this is the classic location, the metatarsals, but they can also be like subtle. You can see here just a little bit of cortical reaction. And don't miss the fractures which are, for example, in the midfoot. This is a fracture of the navicular bone, and it's quite difficult to see them on normal x-rays. If you have any doubts that there is a fracture, please go for MRI, because typically you see the bone marrow edema, which gives you a high sensitivity for detecting stress fractures. Stress fractures of the hip can be disabling, but no wonder. But I still wonder why these super sportsmen are so different from each other patients. For example, Jan Frodeno, a super triathlete from Germany, who won the Ironman several times, published in 2018 that he had to stop his season for a stress fracture of the hip. Not even 1 year later, he won another triathlon in Frankfurt, which is basically something, basically one of the most important Ironman competitions you can win. So it's unbelievable how fast these super sportsmen recover, but they also can have a lot of these problems. So what happened in this patient? You can see this is clearly a teenager or adolescent person, and you can see maybe that there are some subtle changes here in the intertrochanteric region, and maybe you're able to see the fracture line here, which is quite typical problem in adolescent people. If they have a knee trauma, the ACL is not usually torn in between, but they can have a bony avulsion from the tibia plateau, basically. You need to know these facts so that you don't miss this, because this can also be very subtle here. So always look for this area if you have a adolescent with a knee trauma. Another quite frequent fracture is this here. You of course see the fracture here, but what's the name of this fracture? Yes, this is called Sigon Fracture. And what does it stand for? Well, it's usually associated with anterior cruciate ligament injury, meniscal injury, as well as ligaments inserting at the fibular head. And it's basically a friction injury from the epitibial band and the anterior oblique band, which is a band running around the knee. So it's basically a avulsion injury, indicating a major trauma, and you always have to look for ACL injuries in this patient, which are frequently associated with this little type of fracture. So this little type of fracture indicates a major trauma of the knee. We already had one case of a stress fracture of the navicular bone, but here you can see some more fractures of the navicular bone. Here, that's clearly a super fracture, very obvious, not to miss. This is another fracture, also not easy to miss. But this one here is a little bit more difficult. You can see there's a little bit of soft tissue swelling, and here you need to really look very closely. Lisfranc dislocation is something which you need to remember, because it's not always associated with a bony fracture, but it's associated with dislocation and disruption of the situation of the bones in the midfoot. If you see a radiograph, a PA radiograph, you always need to think what about the lines and what you can see. I already highlighted some structures here, and you can see there is a step and a widening of the first intermetatarsal space here, and this is always indicative for a tear of the ligament here, which connects those bones. So if you have a gap here, you always need to consider Lisfranc injury. Some lines may also help you. In CT, which is recommended always if you have a suspicion for Lisfranc injury, you can see usually much more fracture fragments, and you can see also some dislocations in other directions, which are not so obviously to see. And please be aware, even if you see only one single fracture fragment here in a CT, this can indicate that there is injury to the ligaments and an unstable situation. For example, here are more fragments to see. So please be aware that these little fragments give you the hint for some more and complex injuries. Residents should always know about the Lisfranc injury patterns. Of course, you can have complete deviation, deviation of one toe, deviation of those toes in that direction and those toes in this direction. So you can also classify them. You don't need to remember this classification. However, you should remember that there are these different patterns. And then once you remember, you can always look them up in the internet or in some books. So in the past minutes we have talked about some basics, the upper extremity fragments, the thorax and spine, and my case which I did poorly in this race driver, and then about the pelvis and lower extremity fractures.